why don't we just go in reverse order, just while we have Dr. Frank. So the panelists can certainly comment or questions, but I'll give the audience, y'all should have the priority. We have 2 floor mics. Let's start with the radiation talk and we'll work our way back. Peter, do you want to lead us off with, where'd Peter go? Oh, there you are.
Oh, we got a question here. Oliver?
Yeah, we'll do Peter real quick and then Oliver, and then we'll just work our way back through this agenda.
Take your thunder. But Steve, I did have a question. Excellent talk. And obviously, what we need to do is decrease toxicities when we're doing brachytherapy. We know when you looked at all the high-risk patients, how they do very, very well for a long period of time. And so I think it's one of the more curative things we can offer because we're probably treating a little bit more than we can sometimes surgically take out. But that's the opinion of a radiation oncologist, of course. But when you're doing the MRI post-assessment, and if you have to optimize, what is sort of your optimization rate? And then do you have to do a second MRI afterwards? And how do you kind of get that throughput? Because that's a lot of time on MRI scanners.
Yeah, it's a great question. Thank you for the question. So I think with the MRI is actually a single sequence that takes less than 5 minutes. So it's actually, and what happens is once the patient gets there, that sequence, they're pulled out and brought back into the operating room. So the operating room is adjacent to the MRI, and then the patient is there under anesthesia and waiting. And it then takes roughly 10 minutes for our group to be able to then identify the seeds and provide me the information for post-implant assessment. And I've done those, found the seeds myself, pulling it in. We immediately take those images, pull them into the MIM treatment planning software system, and then we have auto contouring, and then we have the seed localization. If the patient requires, and I think probably out of these cases, so far it's been maybe less than 3%, so maybe 3 out of 10 would be probably the right amount. What it's taught me is what the nice thing is I immediately understand what I just did in the operating room. And so if there are 2 things, I can then go back. I usually carry 2 additional needles with strands of seeds so that I can place them effectively. Then I take the patient back in, get the sequence, and then I pull the patient out and wake the patient up. So from a patient perspective, you're saving considerable amount of time because they don't have to wake up. They then can, when they wake up, they know that the implant is high quality. From my standpoint, it's probably a little bit more time on my part because normally if I had to bring the patient back, I'd bring them back 2 days later, maybe on that Friday. I wouldn't do it immediately. But the 2 things that I think that are important is one, have I delivered high quality? And then what can I learn from that implant to improve my next implant? So the positive feedback loop is a critical piece that is largely missed when we try to do day 30 dosimetry because it's very difficult to remember anything that happens in the operating room 30 days ago. But you immediately get this and it is improved. And I would say in the last 30 cases, we haven't taken anybody back because I've identified the areas that I can improve upon immediately with a pre-plan. So those are the things that I think are very important in this quality assurance process.
Yeah, well said, Stephen. Thank you. Oliver?
I was on the net. I was asking a question on Ed's talk, so not radiation.
We're almost there.
Okay.
All right, we'll move on to Ed's talk in one second. I just had one quick question, I collaborate with Steve a lot. This technology piece, and this is why we tried to feature a little bit of technology in all the areas. This is critical from the urologist standpoint. We get involved with, of course, biochemical recurrence, where either you have very difficult biopsy cases, and it almost becomes a game of, okay, I try to biopsy away from the seeds. These are difficult diagnostic cases when you see a rising PSA with or without imaging. And then even more chaotic when you do salvage surgery where we robotically attack these areas from the seminal vesicles forward. So the seminal vesicle base, when we encounter it, it's virtually untreated looking. And then when we get to the apex, it can sometimes be a heavily concreted area of treatment, especially for outside treated dose. And the other observation I'll say, maybe it's in your table somewhere, Steve, I'm sure the average treated brachytherapy primary case is probably late 60s, similar to external beam. It's usually older than surgery. And when you map out how long it takes for them to recur, usually the biochemical recurrent patients are mid to later 70s. And sometimes you have some very difficult trade-offs between how aggressively do you salvage them versus the quality of life trade-offs.
Yeah, again, just the comment, our standard, age for our patients in our published series is is the median age of about 62 to 63. So you're right, that is a little bit older than we see in the surgical series to date. However, more and more patients who are in their late 50s and early 50s are looking for that single outpatient procedure with getting back to work as quickly as possible. So we are seeing a younger population of patients coming through. The salvage patients, those are definitely older because patients typically take 7 to 10 years before they get that recurrence, to your point. And then the high-risk patients, especially when we've started in seeing less patients getting screened, when they come in with a little bit of higher risk disease. So I think that's something that probably will be discussed during the course of this meeting.
Yeah, so I hope you can perfect this because I don't want to see any more salvages. So, all right, let's have Andy move on. We'll talk about the
Thank you.
liquid biopsy talk.
Yeah, well, Oliver, do you want to go ahead? You can ask first question, and then I'll follow up.
No, thank you. Great session. And by the way, I knew nothing about it, but that initial surgery thing was totally cool. So anyway, I enjoyed that. Sent it to my daughter, who's a GYN oncologist. Ed, love the B7H3 in late-stage disease. I'm a little bit curious, how early can you detect it? Because that as an emerging signal will potentially be really important. So I'm curious, you start late, but have you marched it earlier and seen how early you can pick that up?
Yeah. So in the is this on? Yeah. So in the data set that we have in our drug resistance updates paper, it's coming out. It's actually it should be out on the web now. We actually did localized as well. So even with early prostate cancer, we get now the signal's low, but it's higher than it is in healthy donors. So we know that the signal's real and it's coming from the cancer, but it really goes up in MCRPC, which makes sense with where we're trying to target it. But I'm hoping that we can build this into some trials and actually look kind of the way we have with PSMA to see how the target is behaving with regards to the therapy.
Yeah, great work. Congratulations.
Thank you.
And then, Ed, I have two questions for you as a fellow token medical. There's more medical oncologists this year than last year, so that's fun. But I think these are both going to be ctDNA questions for you. The EV work was really cool. I think PSA is like both a gift and a curse to us, especially when we're looking at ctDNA. And I have two of them for you. The first one is when you have a patient who has a very low variant allele frequency and you find something potentially actionable in ctDNA, I think for a lot of people in the room, especially thinking about DDR alterations, how are you approaching those? And then second question for you, thinking BCR, low volume metastatic disease, where we have lower fractions as well. How are you approaching, or like what role do you think there is for ctDNA as like an MRD signal, as Signatera is doing with a bunch of other diseases? And it's complicated for us because we have PSA as well.
Yeah, so both good questions. So let me start with the MRD question because I've actually run into folks now in LA who are sending Signatera on their prostate patients, and it's very confusing. I really don't know whether I can believe or not. Bladder, testis, I'm definitely on board. Prostate, I think there's a lot more subtlety to it, and until I see larger data sets, I don't know. So in the BCR space, how am I really deploying it? I'm really, really not pushing to use ctDNA in that particular setting. But when it comes to these kind of low variant allele frequency changes, I think it's kind of context dependent, right? If you have the advanced CRPC patient who's running out of options and you get a 2% BRCA1 alteration, I think you kind of got to think about whether or not you really want to deploy that in light of that. There's a possibility to work because the ctDNA is only what's being shed. There's other things that are not being shed that that may be more present. So it's probably worth a shot. But if you ask me, would I take a low signal like that and think about using like TULSA in a patient with a very low frequency of like 2%? I don't know that I'd be pushed to make that leap unless I knew there was an emerging very little frequency. And so the one good thing you can do with ctDNA is you can kind of keep looking at it over time to get an idea about how the tumor is reacting. I think that might make a little more of a case, but I think we still kind of got to understand where the thresholds are. And I would say that a lot of liquid biopsy technology that are out there are still kind of emerging and require that kind of prospective validation.
Perfect. And oh yeah, go ahead.
Hi, thank you everybody. Beautiful presentation. So for Dr. Petrovich, I have a question. Like TULSA obviously gives 30% of chance of somebody having residual persistent disease. And so you mentioned salvage with radiation. So do you have any kind of experience about what is the toxicity after radiation? What's the most appropriate radiation in that sense? And also, do you ever do the salvage prostatectomies for these patients? And how does that go in terms of, it's easy to say, well, you have salvage, but then if salvage becomes really toxic, then it's like not a good option. So if you have a little bit more insight, and would you share that with us? Thanks.
Sure. I don't know, can you hear me? Is that, yeah. So, it's very early to really talk about using TULSA for salvage. There's really very little out there. Joe Chin, who was one of the first to use this technology up in Canada, has done salvage prostatectomy and publishes that it goes well. And as surgeons, we're all sort of like, what does that mean? I mean, patient didn't die, there wasn't a fistula, but again, the prostates shrink by over 90% when you do whole gland TULSA. It would be something I would never want to operate on, because you'd have a melted, small, bizarre shaped structure. So I would not recommend surgery, although again, you'll read that it, quote, goes well, quote. I send my TULSA failures to radiation. I know that PSAs seem to go undetectable because the targets are typically small. They get a metastatic PSMA PET, we get an MRI. There's usually a recurrent sort of nodule that is basically kind of all that's left of the prostate. But I can't give you like radiation parameters. It's not my field, and I don't know what goes on there. But that's my default, would be to send them to radiation. And the last answer would be Profound has data that you can repeat TULSA. So if you are taking primary patient, untreated prostate cancer, you do an ablation, let's say, of the left half of the prostate, there's recurrence, one could re-TULSA. And those data are being published. Again, not something I would recommend. If it failed the first time, we have so many other technologies, from cryo to radiation to seeds to anything but doing the same thing twice. But again, that's probably not what the company would suggest.
Follow-up question. I think for most of the people on the panel, except for Ed and I, now with PSMA PETs, I'm more and more finding there's like 25 to 30% of patients who we look, they have BCR after radiation, yet the recurrence is local. And at that point, I feel like there's so many different avenues we can go down. And you were already alluding to some of them, and Steve, you alluded to some really innovative ones as well. As a medical oncologist, I really struggle here because I need to do something focal. I'm not sure what the best approach is, and there's no head-to-head data, and everybody's innovating a lot with small numbers. We have surgeons and radiation oncologists. How do you guys approach, generally speaking, recurrence within the field after conventional radiation?
So I'll just hop in quick. My quick one is, yes, you get the metastatic evaluation. You see the PET glowing somewhere in the prostate. You get a prostate biopsy, I think. You see that is a recurrence in the left base, let's say. I would say cryo is what's been around longest and is easiest to use. Everything else is somewhat investigational. And I think experts that have the ability to offer very well-placed brachytherapy seeds would be another option, again, if the dosimetry, is tolerable.
Yeah,
Yeah, a couple of
thank you.
questions, and And maybe just a reframe too. So when you're doing TULSA, how are we following patients, especially in the prostatectomy trial, which is going through, comparing to TULSA? And you're talking about maybe sparing some of the gland, so therefore you're going to have some residual PSA. So I'm assuming PSA is alpha following, right? How do you do that? And then I want to just talk about all these biopsies we're doing, because we're probably finding cancer which has existed from the beginning of time. We just never knew it was there. Patients were just, running around doing wonderfully. Now we're giving them all these alternative salvage therapies, which they probably don't even need, right? But how are we going to track response after TULSA?
So in the trial, obviously they're not going to go head to head with prostatectomy for PSA outcomes, because there's still PSA after TULSA, because you spare, let's say, the left rim and the periurethral tissues. But they're really looking at health-related quality of life, and was there salvage therapy? Was there BCR that led to treatment in the RP series? And was there, salvage therapy after TULSA, either second TULSA or, something else?
Because they're going to be biopsying in the TULSA group, correct?
Correct.
So they might see some residual something.
Correct. But again, they didn't put that as the primary outcome because they would lose, right?
Right. No, exactly.
Because
And
no
of
one in the
course,
RP
you
is
have
getting
tissue left.
biopsied. So
Yeah.
I give credit to the company for even trying a randomized trial. The amount of people I can convince to randomize themselves to TULSA or whole gland TULSA or prostatectomy is, it's like 1% of the men that I see. But there are others who are more convincing, and in other countries, for example, it's easier to have patients do what hair doctor says, for example, not in the U.S. How do I track patients for TULSA? I mean, they all get an MRI at 1 year, they all get a biopsy 1 year. Forget the trial, like if I'm doing TULSA.
No, exactly. Yeah,
and
real
then
life.
they're on my surveillance list. I follow, more than 1,000 patients on active surveillance, and I follow them. But if the PSA stays less than 1, the initial MRI was negative, I don't do anything other than annual PSAs. And then if the PSA's moving adversely, they get an MRI. If that doesn't look good, we biopsy.
Thank you.
Thank you. Can I ask one to Dr. Frank? So I thought it was a fascinating talk, Dr. Frank, but as a very naive person for brachy, I appreciate all the targeting accuracy that the MRI allows. You don't want to have the VA, sort of disaster from whatever that was. What happens to poorly placed seeds? I mean, your answer could be, oh, that never happens. But like if you notice that they were just not where you want them, can they be removed? Is that possible, or am I up the wrong tree?
No, I think it's a great question. There's two different ways currently for low dose rate that seeds are placed. One is with a MIC applicator. Those are individual seeds. Those get a little bit more. Those are a little bit more difficult when they're placed periprostatically, because then you have the chance that they might migrate. The way that the technique that I use and many use today will be with strands. The strands are nice because they are they're inside of a polymer tube, and so when you place them, you don't get that migration, and you can place them periprostatically and therefore pull the dose outside, especially when you've got tumor that's abutting the capsule. The other piece of technology that I did not specifically allude to, just because I didn't share a publication on it in this talk, is high dose rate. High dose rate is commonly used. It's probably the fastest growing use of brachytherapy in the country and in Canada right now, where those are interstitial with an iridium seed, and catheters are placed within the gland that then allow for the seed to deliver the dose, and then you can remove all of the catheters, so there's no seeds left behind, and the dose is done in a forward planning method. So that also is utilized a little bit more, especially when there's seminal vesicle invasion, which is less common in the strands. So those are some of the subtleties that happen in the thought process of patients that are exposed, especially in the focal setting. I would just say one thing about the cryo, and we haven't had a good head-to-head comparison of brachy and cryo, and I think part of the cryo has not, at least in our institution, become the standard for definitive therapy. And it is utilized more in the salvage setting. I think now that we've also got some salvage opportunities in the brachytherapy space, that there is, there's some shared decision-making in the multidisciplinary setting.
All right. Well, I want to be sure we get a little time for all the talks. We can go a few minutes over, and then we'll off to industry and Super Bowl time. But Dave, this is my standard question on telesurgery because I just think it's fascinating. Because I remember us doing, in the Virginia group, we did some of the computer motion telesurgery between Virginia and Germany and that kind of stuff, and you and Vip did stuff from the early. So the point of that is the demonstration of telesurgery is always interesting, even with the technological improvements. But I've always wondered if the sustained interest in doing it as a regular part of practice is still a challenge, even if you fix insurance issues, licensure, all that kind of stuff. What model do you see this working as a sustained thing, that like every Thursday you're going to do telesurgery somewhere, or somebody's going to do telesurgery, or is it a network? Is it really U.S. among partnered institutions, or the global idea that you brought up?
No, I think this technology can be scaled. Just imagine, how many urologists are in the room? Raise your hand if you're a urologist. How many do robotic surgery? Raise your hand. So here you have a cadre of surgeons. You don't have to be an academic. You can be you can practice in a small community. If you have a telerobotic system that's capable, you guys right here, the smaller community urologists, that technology could be harvested. Your skill set could be transferred to anywhere around the world. Let's start the United States. Think globally. Think in a bigger picture, and that's where the power of this technology is. And I think it would be tremendous to establish a telesurgery cooperative, where maybe we first focus on underserved areas in the United States, but then bring it to a global picture. And we have our European friends that have the skill set that we do. So when you combine that, imagine if every month one of you did one case in an underserved area. Just think of the power of what that could do and how that would deliver healthcare in a different way. And that's the kind of thing that I think you need to think about and how to scale it. We know how to do prostatectomies. All of us do them. We do them with some skill set. I mean, some are better than others, but really we know how to do the operation. It's not a new technology. It's just bringing the technology to the masses. And I think that's where the power of this technology is. And I really believe that will happen at some point, again, before I die. It's good to dream.
That's right. All right, we have a few more minutes we can take, or is anyone else, any topic, any speaker? Or attention spans are done, so maybe we'll cut it there then. All right, well, I hope you enjoyed this sort of a mixed format.